Hey, greetings, everybody. My name is Chris Leonard. I'm the acting chair of the Department of Physiology, and it's my honor and privilege once again to welcome you all to the 11th Annual Drs. Gabor and Harriette Kaley Endowed Lectureship. Today's speaker is here with us, Dr. Julie Freed, and she will be introduced in a proper manner shortly. So I just have a few things I wanted to say first. This lectureship was established through the generosity of Dr. Harriette Kaley, Gabe's wife, and their son, David Kaley, and it has become a fundamental touchstone for our Department of Physiology and indeed for the institution. It's provided an important venue for learning about cutting-edge science and for bringing us together as a community. And so we greatly appreciate their contributions in endowing this lectureship. As one of those fortunate enough to have known Gabe, I can tell you he was a remarkable individual as a scientist. He was a terrific leader of a department, and he was an overall mensch. By celebrating Gabe's career and life, it reminds each of us of the high standards and excellence which we should strive for in our own careers. So we thank the Kaley family for making this possible, as I already mentioned. So before I begin, I also want to thank, before we begin, I want to thank the excellent efforts on behalf of several people in the department. The first Selection and Organizing Committee, which is chaired by Michael Wolin and has Dr. Rhoda, Dr. Wang, Dr. Sun, Dr. Kohler, and myself on it. And we got great advice from many outside people, including Dr. Zucker. And with a special thanks goes to Jeannie Shamus, the departmental secretary, and our educational media team who are helping out today. So the way the program is going to run today is we're going to start with an appetizer, which will be a brief presentation by Dr. Irv Zucker, who gave us a wonderful seminar yesterday. Then we'll follow that with a main course, which where we'll have an introduction of Dr. Freed by Dr. May Rabadi, and then we'll have Dr. Freed's lecture, and we'll have questions then moderated by Dr. Besserier. We'll then move on to dessert, in which we'll have a delivery of the award by Dr. Michael Wolin, and some closing remarks by Akos Kohler. So it's now my pleasure to introduce Dr. Irv Zucker. Gabe was a mentor and an inspiration to many, many young scientists, and who went on to have amazing careers and in science. And in fact, Irv was Gabe's first Ph.D. student and first in a long line of very successful scientists that have come after him. I don't really have time to go into all the details of his spectacular career, but I just say he was the chairman of the Department of Physiology and Biophysics at University of Nebraska Medical Center for 30 years, and he's now the Hubbard Professor in that same department. And he's one of those few people who gave up his chairmanship to not spend more time with his family, but to spend more time in London. So there was no scandal involved, is what I'm saying. So Irv, thank you.
Thank you. I mean, I have a mic.
You have a mic.
Yeah. Thank you, Chris. That was very nice. When Marcello called me and asked me to participate in this event and say a few words about my experience with Gabe, I was thrilled and didn't hesitate for a second to say I will be here. And I'm really honored to share a few thoughts about Gabe and his career. Those of you that actually knew him, this is probably overkill because you understand what he contributed. But Gabe was really a foremost, as Chris said, I was his first graduate student, and he was a real mentor to me and many other people. And this is what stands out. But over the years, I left New York Medical College in 1972, and over the years, we became real colleagues. And we interacted remotely and at conferences many times. And that morphed into something even more important. We became friends. And I always will cherish those days. And what I'd like to do is say a few words about Gabe's contributions to science and to the field, and then some personal musings about our relationships. You know, several people have commented on the importance of mentoring. Steven Spielberg made this comment about there's a delicate balance of mentoring someone. It's not creating them in your own image, but giving them the opportunity to create themselves. And this is the approach that Gabe passed on from his mentoring strategy to those people that left his laboratory. Benjamin Franklin said much the same thing. Tell me and I forget, teach me and I remember, involve me and I will learn. And that's the experience that I've taken away and tried to pass on to my own trainees over the years. So Gabe's career really started with his experience at New York University in the laboratory of Benjamin Zweifach, who was, many people believe, is the father of at least American microcirculatory function. And I know Gabe was very interested in the renin-angiotensin system early on and looked at renin production, renin release in the glomeruli, and those experiences with the Zweifach lab are essentially legendary. He went on to look at a model of hypertension that it seems commonplace, but in 1960 was unique, is the DOCA salt or the DOCA model of hypertension. So this was also somewhat of a seminal kind of paper. And then the effects of high altitude on erythropoietin production. So he was very kind of cardiovascular centric in a lot of the work that he did before he actually came to New York Medical College. Then there was the era of Irv Zucker, and I came in 1968. I look a lot older than I am, and so I had my books in hand, and I was ready to jump into the lab and get stuff done. And together with Norman Levine, who many of you know, we did some experiments that were not related to the mainstream work of the laboratory, but was related to identifying a central mechanism for the sensation of sodium concentration in the CSF, as opposed to a traditional osmoreceptor that was described in the 40s by E.B. Verney. And we did a variety of experiments and showed that there was a prompt natriuresis when we increased sodium concentration in the CSF, and that this natriuresis was mediated in part by the action of the renal sympathetic nerves. So these were kind of unique experiments, and I remember many, many hours in the cone building in the basement, didn't know if it was raining, sunny, outside, and doing many, many measurements of GFR, looking at inulin clearance and things like that. And those kinds of things, I think, really helped me learn the scientific process. Then there was the era of prostaglandins. And I think that this is one of the things that Gabe will always be known for. He and Richard Weiner in the laboratory showed for the first time that PGE inhibited the vasoconstrictor responses to a variety of agents, including angiotensin, epinephrine, norepinephrine, vasopressin, et cetera. And this became somewhat of a legendary observation published in the American Journal of Physiology that I have a fondness for. The other major push by Kaley and Weiner was the role of prostaglandins in inflammation. And using the Evans blue technique to look at plasma extravasation in the skin, they showed the importance of prostaglandin in the inflammatory response. Then there was the Ed Messina era. And these were also very important experiments. And I remember watching Ed set up his mesentery preparation and his cremaster preparation with very meticulous control of temperature. And there's a long story about the Marriott jar bottle that I won't bore you with. But these experiments showed that prostaglandins could inhibit vasoconstrictor responses, even long after the vasoconstrictor responses were terminated, the acute effects were terminated. And of course, Ed and I have become great friends over the years and almost like brothers in many ways. So I will always appreciate those days in the laboratory when we became very close. And being in the basement, by the way, you had to concentrate on what you were doing because there was nothing to look outside for. Then there were the important experiments done by Tom Hinsey on coronary blood flow. When he came back from Steve Vatner's lab at Harvard, he showed that, that prostaglandins mediated in part the coronary reactive hyperemic response. And these were done also in canine models, looking at repayment to debt ratio following vascular occlusion and release. And these were actually classic experiments as well. Now, all of this led up to some major insights and major papers, along with Phil Needleman. Gabe and Phil published a landmark review paper in the New England Journal of Medicine that really stressed the importance of a variety of prostaglandins and products of arachidonic acid. And one of those products was prostacyclin, or PGI2, as it was sometimes called. And all of this led to a variety of seminal work, culminating in the Nobel Prize in Physiology and Medicine that was shared in 1982 by Bergstrom, Samuelson, and John Vane. And I remember very clearly at an experimental biology meeting, John Vane talking about this work and saying that what he does every morning when he gets up is he licks an aspirin. And that was, I think, profound. Gabe and Burton Altura, his longtime friend, published a 3-volume book. They edited it on the microcirculation, which in the late 70s, which still remains a great compendium of the work known at that time. It would be remiss of me not to talk about the Kaley-Kohler era. And here's where I think there's that much of Gabe Kaley's work and Akos's Kohler work is remembered because of the idea that the endothelium are critically important in flow-mediated dilation, and showing that one can get an increase in diameter in a microvessel as you increase velocity of flow, and that is completely prevented by destruction of the endothelium, right? And this has been reproduced over and over again. This has been confirmed in humans as well as in experimental animals. And it's a very important regulatory mechanism, I believe. Those types of experiments were continued by younger people that have come to the lab over the years. An Wang and Deng Wang and Zsolt Bajcsy contributed a variety of papers over the years that reinforced the idea of flow-mediated dilation, the role of nitric oxide, the role of oxidative stress, differences between genders, a whole variety of really important papers. And then this whole idea of flow-mediated dilation was put into a book that was edited in part by Gabe and colleagues. So let me just finish by a few personal musings of my relationship over the years with Gabe. In 2002, there was a book published that I became aware of later on, and I read this book avidly. And this book, written by Tom Rajo, was a discussion of a group of friends that were rounded up during the Nazi invasion of Budapest and sent to a Yugoslavian labor camp. And it was a history of the interaction between these 3 or 4 friends. And one of the passages from this book, in my mind, typifies Gabe's joie de vie, his love of life. And that is reproduced here. He says, weeks passed and we began to organize ourselves. Sometimes we started daydreaming out loud. Kasha, who was Gabe Kaley, was his name, would talk of future feasts. He would recite the menu out loud. A whole duck just for himself, garnished with oranges and stuffed with chestnuts, coated with chocolate, decorated with whipped cream, and basted with cognac. Every day he would add something to the recipe. And my interaction with Gabe and the dinners we shared literally throughout the world is some of the fondest memories I have of this relationship. I was lucky to, after I became chair of physiology at University of Nebraska Medical Center, we were lucky to give Gabe this McIntyre Award. He came to visit us, and I've been trying to get him to visit Omaha for years, but he was somewhat resistant until I came up with this mechanism of giving him an award. And one of the things that Gabe said in his lecture was, there are satisfactions delivered through a long career in science that far outweigh what I imagine I would have accomplished as an MD. The pressures now in science are greater than ever, which is still the case. Remaining creative is a full-time job, and I relish it. As my biochemistry teacher, Albert St. Georgi, who won the Nobel Prize in Physiology or Medicine, said, a good scientist has to see what everybody sees and think what nobody else has thought. And those are really profound words. Gabe loved his home country, loved traveling to Budapest. I was thrilled to be able to accompany him on several excursions to Budapest. And here you see a photo of Harriette, Gabe, and my wife Judy in a suburb of Budapest. And it's an absolutely beautiful city. And we were honored to be there when Gabe was awarded an honorary degree at Semmelweis University. Akos, Tom Hinsey, myself, and I know Harriette was there, and we really, that was an absolutely pleasant time. We were chairs together. Gabe was one of the longest serving chairs of physiology departments, 37 years, remarkable. I wasn't as good. As Chris said, I gave up the ship after 30 years, but we got together almost every year at the ACDP or chairs meeting and interacted, and those are also cherished memories. And then there's one last story I want to relate. Is Gabe, as many of you may know that knew him, was very competitive. And I went to China for the first time in 1987. And I walked up the Great Wall. And Gabe said, I can do better. And so when I got to the top of the Great Wall, I had to put this note together, which is hard to see, but what it says is, Zucker 100, Kaley 99. I walked a few feet further than Gabe. I just want to finish with a short video, if you'll indulge me, on what I think. The other thing about Gabe is he was philosophical. He really thought about the importance of science and the importance of thinking about how people contribute to the field. And in an interview coordinated by Ed Messina as part of the Living History Project of the APS, he said what I'd like to show you here.
Not just use techniques, the very same technique all the time. The other trick, of course, is that all students have to read a tremendous amount. You have to be aware of what goes on in science, and you have to read all the relevant journals, and then make your decisions what project you are going to pursue. I believe that science is essentially a glorious profession, even though it's a very difficult one, because it requires a tremendous amount of effort and commitment to the task. But it is glorious. As somebody has said, it is not the gaining of knowledge, it is the quest for truth that makes this a very exciting field and fascinating and quite often gratifying. Perhaps not quite often gratifying, but occasionally gratifying, which makes up for all the hard work that one does. I always think of a kind of a metaphor when I think of how contributions to science are made, and that is perhaps would be good for students to know. And that is, I conceive of the development of science as the building of a great Gothic cathedral. There's no single architect. Everybody is working all the time, throughout the years, centuries sometimes, to build this cathedral. And everybody is contributing. Some of us, the great ones in our field, perhaps work at the very foundations of this building. Others are making just little adjustments or paint the wall a little bit. But all of us, regardless of the work, the nature of the work, positive or negative, contribute to this great effort, to this great edifice, to this which has great beauty. And this is how science develops. Even if you don't happen not to contribute much, or your contributions are on the negative side, you are still contributing.
I did not prepare remarks today because this is the 11th occasion for this lecture, and I think I've said a lot of what I wanted to say about Gabe in the past. I'm going to repeat a little bit of it, though. I am so gratified to be here. Establishing this series of talks was very important to Gabe, and I'm very glad that David and I were able to fulfill this. It was part of Gabe's love of science and the way he said a couple of times about dying that the only thing that would really upset him about that was that he wouldn't be able to track the scientific developments that happened after him. I was a little perturbed that he didn't talk about missing me, but I sort of took that for granted. There are some things that I want to say about Gabe that duplicated what's already been said, but they were really important. Gabe had a tremendous, what I think Irv just called joie de vivre. He had such vitality. He enjoyed life tremendously. Give him a chance and he would be singing and just smiling. He loved his team here. He would talk about going to the annual meetings, the FACET meetings and various others, as meeting up with his people. And he really relished it. There are lots of stories about Gabe's charisma that drew people to him. One of the minor outgrowths of it, I understand, was how the department all ate lunch together at the same time in the library, somehow surrounding Gabe or something like that. He drew people to him, and I can't say he loved people. He was very particular about who he let into his inner circle. Wouldn't you agree, Chris? And yeah, yeah, he was careful about who became close to him, and the ones that did, he loved inordinately. What else do I want to say? I want to say one or two other things. I'm glad that Irv talked about Gabe's time in Hungary. I really want it known that Gabe was a survivor of the Holocaust. Please do not let anybody tell you that it didn't happen. Gabe was sent to a slave labor camp in Bor, Yugoslavia. And one of the reasons he survived was that there were railroad tracks in this mining area to trek the copper to where they needed it for the Nazi war effort. Gabe was assigned to that outdoor assignment. Most of the people who were there, his friends, they were 17 years old then, were miners in the copper mines. They did not do as well as those who worked in the open air. Gabe came here entirely alone, with not a penny to his name. He talked about walking from the tip of Manhattan Island to the room where he was staying in Upper Manhattan, and he had to walk because he didn't have the fare. He never really complained about that. As a matter of fact, when Gabe told me about his experience during the war, he made it sound like it was an extension of his Boy Scout experience. Really, he had that kind of optimism and resilience. He was very lovable, and he loved me, which is something that comforts me every now and then when I think about it. And, in hard times, I have to tell myself that Gabe loved me. That means that all of the hard things that couldn't get resolved just disappear. What else do I want to say at this point? He loved science. He loved the people he worked with. He loved being alive. He had a kind of vitality. I'll tell you two little incidents. Irv, this one is for you. When Irv was still a student and Gabe was not yet chair, Gabe went to work with wearing a new shirt. It was a navy blue, I think, in some interesting way. And Gabe came home chuckling because Irv had taken one look at him and dubbed him "Kid Stunning." Do you remember that? Really? He had no respect for, Gabe had no respect for sacred cows, and I guess telling that story, Irv had no respect for sacred cows either. And what was the other one? I can't remember the other one I was just going to tell you. Well, I think I've given you a sense of who he was. I see smiles on the face of those of you I know who knew him. He was that kind of guy. And I'm very gratified that this lecture series has become an established institution. Gabe would have been happy about it.
Thank you for joining us today at the 11th Annual Drs. Gabor and Harriette Kaley Endowed Lectureship, hosted by the Physiology Department. Today, I have the honor of introducing Dr. Julie Freed from the Medical College of Wisconsin in Milwaukee, Wisconsin. Dr. Freed has a very impressive resume. She is a board-certified anesthesiologist and an associate professor in the Department of Anesthesiology, with additional faculty appointments in the Department of Physiology and the Graduate School of Biomedical Sciences. She is also the Associate Director of the Cardiovascular Center, Clinical Research Director of Anesthesiology, and Executive Vice Chair of Anesthesiology at the Medical College of Wisconsin. Dr. Freed completed her undergraduate studies in 2002 with a bachelor's degree in physiology from the University of Minnesota. She then continued her education and graduated with her Ph.D. in 2008 from the Medical College of Wisconsin. Following her Ph.D. studies, she received her M.D. in 2011 also from the Medical College of Wisconsin. Dr. Freed then went on to complete a residency in anesthesiology at the Medical College of Wisconsin in 2016. At that time, she was a Ruth Kirstein Institutional National Research Service appointee. Next, she completed her fellowship in 2017 in the field of adult cardiothoracic anesthesiology in the Department of Anesthesiology at the Medical College of Wisconsin. Dr. Fried has many awards and honors from different societies, such as the American Heart Association. Recently, she was named Mentor of the Year and won the Outstanding Service Award from the Medical College of Wisconsin. She is also on numerous editorial boards, including the editorial board for the American Journal of Physiology, the Journal of Cardiovascular Research, Anesthesiology, and Circulation Research. Dr. Fried is the Senior Associate Editor of the Journal of American Heart Association and Associate Editor for the Microcirculation and Journal of American Heart Association. She has also served on multiple grant review study sections. Dr. Fried has many active research grants and awards, including 3 current NIH R01 grants in the field of microvascular and endothelial function. 2 other NIH grants, including an R38 and a T32 training award and a CTSI pilot award. Dr. Fried is very active in research and has mentored many students in her lab, including undergraduate students, medical students, graduate students, and junior faculty, and has over 60 publications. Dr. Fried's primary research focus is on human microvascular endothelial function. She focuses on the role of sphingolipids, that role that sphingolipids have in the development of endothelial dysfunction in the human microcirculation. So elevated plasma levels of ceramide, a prototypical sphingolipid, are now considered an independent risk factor for major adverse cardiovascular events in otherwise healthy people. Dr. Fried's lab is currently investigating how these bioactive lipids are regulated in the human endothelial cells. She is also interested in intraoperative blood pressure control, including mechanisms and treatments of vasoplegia. Her other interests include translating her work in the lab to improve outcomes for surgical patients. We would like to thank Dr. Fried for coming to New York Medical College to present her research. The title of her presentation today is Translational Tales of Human Microvascular Endothelial Function. It's my pleasure to invite Dr. Fried to present her wonderful research.
Well, thank you so much for having me here. Actually, I'd like to start out with a few comments myself. You know, I have to say there are moments and times in our life that just leave such huge impressions on us, right, that we'll remember forever. And I had one last summer. So last summer, I was invited to give a lecture at the Mechanisms of Vasodilation meeting. This meeting only happens every 3 to 4 years. Last summer, it was at Oxford University. And after a day of programming, we got to go into the dining hall of Magdalen College. It's a very historic place. We walked in, I was standing next to my colleague from the Netherlands, and I turned to her and I said, "So where should we sit for dinner?" And she says, "Well, should we sit next to Ecos Kohler?" And I turned to her and said, "I don't know. Are we allowed to?" Because you look around the room and you see a bunch of legends and outstanding vascular biologists, and it was very intimidating. And so we did. We sat down next to him. We had a lovely dinner. We share a love for sports. We talked about the Olympics. The Olympics were happening last summer. And then the conversation shifted towards the life and career of Gabor Kaley. And I just want to say to Dr. Kohler, thank you so much for that moment. Again, big lasting impression. I'll remember it for the rest of my life and the rest of my career. Because science is not, I guess, just always about finding the truth and doing our experiments. It's about the relationships that we form throughout our career and our lives. So thank you from the bottom of my heart for this opportunity. I never got to meet him. I think I saw him from afar when I was a younger student, but I never got to meet him. But talking to Dr. Kohler that night, hearing the stories last night at dinner and today, and you'll see my research directly relates to what he established. So thank you so much for this opportunity. So I thought I'd start us out with a quote to kind of get us around a theme here. Speaking of reputations of former scientists, and that is that it takes 20 years to build a reputation and 5 minutes to ruin it. And while I agree with Warren Buffett, right, this might pertain to personal reputations, it's not always the case in science, research, and even medicine, right? We develop our ideas, our hypotheses, we develop enormous amounts of data when we develop dogma. And sometimes it's hard to kind of change how we think about something, especially when it comes to reputations and ideas about certain topics. And today I'm going to kind of challenge you to maybe think differently about some things I'll be discussing. So the goals for today's talk, I'd like to discuss the importance of the human microcirculation. I don't think that'll be a tough sell for this group, but we'll talk about it nonetheless. I'm then going to talk about the so-called bad reputation of this lipid called ceramide that we've been studying for a number of years and how it promotes microvascular dysfunction and, yes, is a predictor of future cardiac risk. But maybe we don't know the whole story there. And then I'm going to switch gears a little bit and pivot to a different sort of reputation and talk about estrogen. And I promise I'll tie the two together. But traditionally, this is a compound, a sex hormone that is thought to be a good player as far as vascular function and promoting vascular protection. I do have one quick disclosure. I am a consultant for AstraZeneca. I will not be talking about anything with those projects today. Okay, some more pictures. These are my children. This is William and Elizabeth. If you don't know what's happening here, maybe find me at lunch and I'll explain it to you. Again, we're a big sports family. But we have a little fun game in our house. Every day they like to ask me, where were you today? Were you in the hospital taking care of people? Were you in the laboratory? They think it's wild that you can do two different things. And they're right. You know, I start my week out as a cardiac anesthesiologist, taking care of people that look like this, right? People that are at the end stage of cardiovascular disease and they are literally dying from it. So in this case, this patient is on all sorts of machines and equipment to stay alive, ventilators and ECMO circuits, and this is who we're taking care of. We're taking people off helicopters, right? People who are suffering from cardiac arrest and putting them on these devices. I would say my career as an anesthesiologist has changed. I still sit in an operating room and take care of these patients, but it's become very much more, again, high risk. More and more people are coming in like this, and the age at which they're coming in is much younger. So again, this is how I start out my week. One day a week, I take care of people like this. And then what's fun is I get to go back to my laboratory and understand how cardiovascular disease even begins. And while traditionally we think of heart disease as affecting the main large conduit coronary vessels, we now know that that's not quite the whole story. The myocardium should be bathed in a microvascular network. These little tiny microvessels are not only critical in controlling myocardial perfusion, but we now know that dysfunction in these small vessels is what leads to future disease, atherosclerosis, heart disease, and even some forms of heart failure. I think that concept is illustrated quite nicely here by this study done by Van de Hoff and colleagues in 2014. So let's see if I can use my mouse here. So here we're looking at cumulative MACE rate, or major adverse cardiac event rate, in time since procedure. And the procedure in this case was a cardiac catheterization. So these are patients that came to the hospital with chest pain. They got a trip to the cardiac cath lab. And they did a really interesting study. They looked at both large artery and small artery function and then followed them for about 10 years after the cardiac catheterization. And what you can see here is that those that had both normal large artery and microvascular function, yes, over time you saw a little bit of an increased MACE rate. After all, age is the #1 non-modifiable risk factor for cardiovascular disease. But what was interesting is those that had abnormal large artery function, but a normal microvascular saw a little bit of an increased MACE rate. But what was really compelling is those that had, despite a normal coronary, large coronary system, those that had microvascular dysfunction, you saw this tremendous increase in MACE rate over time. Now, a few years later, another group brought patients back to the cath lab, and they wanted to correlate what they were seeing in the peripheral microcirculation to what they were seeing in the heart. And so here we're looking at changes in coronary blood flow with adenosine and changes in femoral blood flow with acetylcholine on the x-axis. And as you can see, they do correlate. Now, there have been a bunch of other studies now in the past couple of years showing that peripheral microvascular dysfunction, yes, does predict poor cardiovascular outcomes. And the summary here is that the peripheral microcirculation, therefore, can be leveraged. It might provide a window into what's happening in the coronary microvasculature. After all, we don't want to take everybody to the cath lab. That's pretty invasive and very expensive. So if we can utilize the peripheral microvasculature, that would be wonderful. So how do we, in my laboratory, look at microvascular endothelial function? We do study flow-induced dilation, something Gabor Kaley was, of course, very familiar with. So we do flow-induced dilation. It's exactly how it sounds. It's the ability of an arteriole to dilate in response to an increase in blood flow. Now, I'm a little biased, but I do think this is one of the most important physiological mechanisms we have because it does help match blood flow, supply, and demand. So if we were to zoom in on a peripheral arteriole here and even further to see the endothelial cell and smooth muscle cell below, again, we know that an increase in blood flow or shear stress felt along the endothelium is going to be sensed by many mechanosensors in the cell wall. That's going to generate vasodilatory compounds in the endothelium, which then get released and act on surrounding smooth muscle to cause relaxation. Now, at the Medical College of Wisconsin, and many of you are familiar with this from my research mentors' prior work, we're able to do this in human microvessels. And we're able to do this because David Gutterman started and opened an IRB many, many years ago that allowed us to collect otherwise discarded surgical specimens from the operating room. So in other words, when a surgeon was taking out something from the body, if there was excess atrial tissue from the heart or adipose tissue, if it was otherwise going to be thrown away, the IRB allowed us to kind of say, stop, we'll take that, we'll collect it. It would then get sent to the MCW tissue bank that acts as our honest broker. That's where the specimen becomes de-identified, and then we have to take it to the laboratory for dissection. So again, this was started around 1995, and if we do it through this true discard way, you get some basic demographics. You'll get age, BMI, sex, maybe some major comorbidities. And then in 2020, I took it a step further, and I opened a consented bank. I would like to, if at all possible, consent these patients prior to surgery, let them know that we're taking their discarded tissue, and then we also get more patient information. So we've been using kind of both systems to get those specimens. Once we dissect out the arterioles, again, from atrial or mostly adipose tissue now, we use a pressure myography system to do and study the microvascular reactivity. So that's shown here. We dissect out arterioles, usually around 100 to 150 microns in diameter. They're very small. And we cannulate them on glass micropipettes of matched resistance. These little pipettes are then connected to reservoirs which are open, which allow us to pressurize the vessel. And of course, this is done in an organ chamber with oxygenated Krebs buffer. So in order to induce flow through the system, it's rather simple. You just raise and lower the heights of the reservoirs in equal and opposite directions. That allows an increase in flow without changing central vessel pressure, which is key, because we don't want to cause a myogenic response. We can then add inhibitors and other agents into this organ chamber to determine what exactly is causing the dilation. And so I just want to kind of summarize, this is a very simple schematic shown here. Again, we're looking at an endothelial cell and a smooth muscle below it. This is what we would expect to see if we were studying an arteriole from a healthy adult. That increase in flow is going to activate endothelial nitric oxide synthase, which then generates nitric oxide, which then diffuses out of the endothelial cell and causes vasodilation, acts on that surrounding smooth muscle. This was discovered in 1987, and the Nobel Prize awarded in 1998. However, in the diseased state, in an arteriole from a patient with coronary artery disease or with multiple risk factors for disease, we know this mechanism changes. So we know that in disease and in endothelial dysfunction, there is this large amount of reactive oxygen species within the cell. A lot of superoxide is produced from many mechanisms, but primarily we believe from the mitochondria. And that superoxide can quickly bind with nitric oxide to form peroxynitrite. It now has a negative charge. It can't leave the endothelial cell. It can't cause vasodilation. But our bodies are smart, and we're able to compensate during times of stress and disease. The superoxide can be converted to hydrogen peroxide, which, like NO, can diffuse out of the endothelium, cause hyperpolarization of the smooth muscle cell, and you can dilate. And I just want to say again, I think this is absolutely fascinating that even during times of disease, we're able to maintain this critical mechanism of dilation. So if I were to do this experiment today, and we were to collect a piece of adipose tissue from a healthy patient, which means they have 0 to 1 risk factors for coronary artery disease, this is what we would expect to see. This is our typical flow-induced dilation curve, where we're looking at percent maximal dilation on the y-axis, and then the pressure gradient, or that change in flow, on the x-axis. And as you can see, as we increase the flow, the vessel dilates out quite nicely to about 80%. If we were to repeat this experiment, except this time put the NOS inhibitor L-name in that organ chamber bath, the vessel can no longer dilate. But if we were to do this again, and instead of L-name, add catalase, which promotes the breakdown of hydrogen peroxide, it doesn't have an effect. And that tells us that the primary mediator, or vasoactive mediator, produced from the endothelium in this case that's causing the dilation is nitric oxide. Now you do this experiment again, except this time the piece of adipose tissue comes from a patient with coronary artery disease. Maybe they were having a CABG done in the operating room. Again, the vessel dilates out quite normally to about 80%. Again, even in times of disease, we can maintain this mechanism. Except this time, L-name has no effect, but catalase completely abolishes the ability of the arteriole to dilate. Now this tells us that the change in mechanism has occurred, and we see a switch that's no longer utilizing nitric oxide, but it's now primarily focusing on using hydrogen peroxide as that mediator. So when I joined David Gutterman's lab many years ago now, and I think about it as a trainee, this is kind of where we were. You know, he had discovered that this transition happens in disease in human microvessels, but we were really trying to understand what were the triggers, what were the stimulants that were causing this change in mechanism. And so I wanted to give you just It turns out there are many, but I'm going to give you one quick one, which is high pressure. So in this experiment, this was done by David Gutterman and Andreas Beyer. They dissected out microvessels from otherwise healthy adults, again, 0 to 1 risk factors for disease. And then using that pressure myography system, they simply raised the heights of those reservoirs up to about 150 millimeters of mercury for 30 minutes, just completely stressed out the vessel by increasing that pressure. After 30 minutes, they took those reservoirs back down and they went ahead and did the flow-induced dilation studies. And as you can see, again, these are arterioles that came from healthy patients that should be vasodilating to nitric oxide are now utilizing hydrogen peroxide. So just 30 minutes of high pressure can cause that transition in mechanism. But what's more important is we have seen over time that that compensation can only go so far. We can utilize hydrogen peroxide, and I tell people it's kind of like that spare tire in your car. It's there if you need it. You just don't want to have to rely on it all the time, right? It's not good for us. We know nitric oxide is very anti-inflammatory, antithrombotic. Hydrogen peroxide is just the opposite. It's very pro-inflammatory. The issue here, though, is if you already have risk factors for disease, or if you have coronary artery disease and you're utilizing hydrogen peroxide, additional stress, which is what's shown here on this other graph, will actually start to cause an impairment in the ability to dilate to flow. So in other words, that compensation can only take you so far, and added stress will cause more damage, and that damage usually is represented by a loss in vasodilatory amplitude. So again, microvascular stress, it's no surprise, right, triggers this transition from nitric oxide to hydrogen peroxide. But again, once you're already using that compensation, any further damage can cause you to lose the ability to dilate. So to summarize this first part, microvascular dysfunction is a strong predictor of future adverse cardiac events, and that's whether you see it in the coronary system in your heart or in the peripheral microcirculation as well. No surprise here, but exposure to vascular stress, and I only gave you just one quick example, can promote microvascular endothelial dysfunction. And again, that dysfunction, at least what we study in the laboratory, can manifest as that transition from nitric oxide to hydrogen peroxide mediated dilation. And then again, added stress will ultimately reduce the ability to dilate. So I thought I'd start now by talking about the bad reputation of ceramide. This is a lipid, it's a sphingolipid that we've been studying for quite a while now. And I want to talk to you a little bit about how this all started for us. And that is, first, here's what the compound looks like of ceramide. It's a sphingolipid, which means it has a sphingosine backbone. And then, like a lot of lipids, it has a fatty acid chain of varying length. So there's all sorts of types of isotypes for ceramide: medium chain, long chain, ultra long chain. And this was really a landmark study that was published in 2016. This is the FinRisk study that occurred in Finland. They followed a cohort of people starting in 2002. They followed them for 13 years. And they measured their ceramides and then looked at survival probability. And here they're looking at, I'm just showing one particular ceramide, which is 18-1. It's a long chain ceramide. And as you can see, they broke everybody up into quartiles. And those that had the highest amount of ceramides, as you can see, they didn't survive as well, showing us that these ceramides might be predictive of survival probability, even more so than LDL, right? So this was a little surprising. And it led to quite a bit of attention. This is, in fact, an editorial written by Scott Summers, can ceramides become the new cholesterol? Well, sure, maybe. Right now, there's only one place you could measure your plasma ceramides, and that's at the Mayo Clinic. But this editorial, to his credit, he said, well, why would you measure it if you can't treat it? In other words, we don't have ceramide-lowering drugs right now like we do statins. So again, if you wanted to get your ceramides tested, you'd have to go to Mayo Clinic. But if they're high, there's not much we can do about it right now. We became interested in ceramides also because we've known for many years that ceramides cause mitochondrial dysfunction and increase mitochondrial oxidative stress. So putting all this together, a first major hypothesis was just rather simple, that exposing these healthy arterioles to exogenous ceramide would cause that transition in mechanism, and the vessels would have to rely on hydrogen peroxide. So again, for this study, we actually use a short chain ceramide, C2, that allows it to get into the endothelial cell, but once it's in there, it does actually convert into the longer chain ceramides. And I always hate saying this in a room of basic scientists that study animals, but chronic for us, for the treatment of these arterioles, is about 16 hours or anything over 4 hours, right? We have to use these vessels within 24 to 72 hours. So when I say chronic, bear with me, it usually means anything over 4 hours. So for this study, we treated them with the C2 ceramide for 16 hours chronically. And as you can see here, compared to vehicle, the vessels do just fine. After the treatment with ceramide, they vasodilate out to 80%. Here we're looking at normal healthy arterioles that are inhibited by L-name, but those treated with ceramide, as you can see, vasodilate just fine. But then we see that flip with the catalase. The catalase doesn't have an effect in the healthy arterioles, but those treated with ceramide are now inhibited, telling us that that transition in fact occurred. We wanted to make sure this was exclusive to the endothelium, so we also treated vessels with ceramide and gave an NO donor, in this case sodium nitroprusside, SNP. And as we did that dose response curve, we can see that both vessels dilated just fine, indicating that the smooth muscle function was okay. At the time, it's not anymore. This was also a novel fluorescent probe that we used in the human arterioles called mitoperoxyellow-1. It detects mitochondrial-derived hydrogen peroxide. And this data is just showing that those, again, treated with ceramide, at 1 minute and 5 minutes of max flow, you see this really large amount of mitochondrial-derived hydrogen peroxide being formed. And so the conclusion here is that yes, chronic, again, exposure to exogenous ceramide does promote that transition to hydrogen peroxide-mediated dilation. It's not just giving the ceramide, it's not just giving it exogenously. We also believe it's endogenously created or ceramide accumulation. There's a couple different ways you can make ceramide in your endothelial cells. This is one pathway we've been focusing on for a while now. There's an enzyme in the plasma membrane called neutral sphingomyelinase. This is a very rapid way to create ceramide. And what's interesting is once the ceramide is produced, it can rapidly be hydrolyzed by ceramidases to form that backbone sphingosine, which can then be phosphorylated to form sphingosine 1-phosphate, or S1P. And what's interesting about these lipids is they have two very different opposing actions. Again, I'll show you, as you just saw, ceramide is a strong inducer of mitochondrial dysfunction and ROS, whereas S1P seems to be the good player here and is very creates nitric oxide, promotes survival pathways within the cell. So for this experiment, it's very crude, but this was many years ago now. We took arterioles from, this is non-CAD or otherwise healthy patients compared to those with disease, and we actually looked at the expression of neutral ceramidase using immunohistochemistry. So I kind of zoomed in here for you, and this red arrow is kind of showing the endothelium, and as you can see, there's a lot of brown staining there, very crude, but in the CAD arterial, the person with disease, we don't see as much expression there. So we thought, okay, is it possible that during coronary artery disease and endothelial dysfunction, you have increased accumulation of ceramide? And so for this experiment now, we went back to the microvascular reactivity studies. We took arterioles, again, from healthy patients. The first thing we did is we inhibited ceramidases using ceranib-1, and sure enough, they went from NO to hydrogen peroxide. We went downstream a little bit. We used a small molecule inhibitor to inhibit sphingosine kinase, and sure enough, they went from NO to hydrogen peroxide. So a summary here, manipulating these pathways or the sphingolipid rheostat could actually cause accumulation of ceramide and the same sort of dysfunction you'd see with the exogenous. So the major question then became, okay, well, that's great that we can use ceramide to cause the dysfunction, but in arterioles from patients with disease, can we restore nitric oxide-mediated dilation? And so this was an interesting study. We took those arterioles from patients with disease, and we used an inhibitor of neutral sphingomyelinase, GW4869. And well, for the first time, we were able to take a vessel from somebody who's had disease for years and revert back to nitric oxide-mediated dilation. So we were very happy about that. We took it one step further a few years later. This is the first time that we created an adenovirus to do a gain-of-function study in an arteriole. And the goal was to overexpress ceramidase in these arterioles from people with CAD. And so the data is shown here. We created an adenovirus with a dual promoter system that could express GFP as well as neutral ceramidase. So this middle panel here is just showing that the control with just overexpressing GFP, these arterioles from diseased patients still utilize hydrogen peroxide. But if you overexpress ceramidase and force the hydrolysis of ceramide, we could also restore nitric oxide-dependent dilation. So the summary here is that yes, inhibiting ceramide formation through this pathway or increasing its hydrolysis and breaking it down might be a method to restore endothelial function during disease. So I hope to this point, I have made the case for you, and I've just supported the reputation that ceramide is bad, right? And very bad for the microvasculature. But there was something that was keeping me up at night, and that is the fact that this enzyme that creates ceramide is flow sensitive. And that really bothered me. If I just explained, right, how important this mechanism is for tissue perfusion. So why is it that we would create ceramide in response to an increase in flow? And at the time, I had a very bright and motivated student, an MSTP student, Gopika Senthu Kumar, joined my laboratory. She was interested in coming to the lab. I told her we were talking about this. And I said, well, what do you think about this? And I showed her some data also from many years ago. This was over 20 years ago, showing that in cultured aortic endothelial cells, they gave a small amount of ceramide, and using DAF2, they could see that nitric oxide went up compared to vehicle, and it was suppressed by LNNA. And this bothered me as well. I said, Gopika, there's more to the story here. And like it was already mentioned today, the goal is to find the truth. So we could keep going down this path of, yes, ceramides are bad and they do all these terrible things, but we really have to get to understand what is the role of ceramide in microvascular function. And so one of the first experiments she did, which I thought was pretty unique, we did a dose response curve in these healthy arterioles to ceramide. Not thinking ceramide is going to be by any means a robust vasodilator, and it's not. As you can see, as we increase ceramide, you only dilate to about 40%. But the important part is that you didn't see that dilation with both L-name and a nitric oxide scavenger, CPTIO. So the conclusion here is that yes, ceramide might be a critical signaling component in the formation of nitric oxide. So there's always more to the story, and it may not be as bad as we thought. So she took this a couple steps further. She did a very critical experiment where she took, again, arterioles from healthy people, and she just inhibited neutral sphingomyelinase. And we thought, well, if it's that critical during flow-induced dilation, then maybe the vessel won't dilate. We were wrong. In fact, it utilized hydrogen peroxide. Makes me feel a little bit better. Again, when you block one pathway, we can compensate. So again, you take a healthy arteriole, you inhibit ceramide formation, you actually cause dysfunction. She also looked at nitric oxide formation in these vessels. So here, compared to control, at 1 minute and 5 minutes of max flow, you can see nitric oxide increasing. That is not happening in the presence of L-name, so just showing probe specificity. And then as you can see, if we inhibit neutral sphingomyelinase in response during flow, you don't see nitric oxide increase. But like I said, ceramides are constantly in flux. They can be hydrolyzed, broken down, they can turn into S1P. And to take this one step further, Gopika said, well, what if we just added S1P back into the system? And so she took these arterioles, she inhibited them with the GW compound, but then added back one S1P. And as you can see, S1P alone actually does increase nitric oxide production. But in response to flow, and the data is summarized right here, you do actually restore the ability also to generate nitric oxide during flow. She hates it when I do this, but I basically summarized her whole thesis on one slide. There's much more to this story. This was by far one of the largest studies we've done in our laboratory group. The paper that she published included arterioles collected from over 160 patients. So there's definitely more to the story, but the gist here is that, yes, the beneficial effects of ceramide formation during flow is likely due to the fact that we have to convert it to S1P. So to summarize the second part, it's administration or accumulation of endothelial ceramides that promotes microvascular endothelial dysfunction. Ceramide generation through this pathway looks like it is absolutely necessary for endo generation during flow. And the beneficial effects from ceramide are likely due to that conversion to S1P. I say likely because I always talk soft, right? We never seem to know the whole story. Okay, I'm going to switch gears a little bit here and talk about estrogen. And again, I promise you'll see how these two are connected. Estrogen, again, is typically thought to be a very vascular-friendly protective compound. And we'll see if I can change your mind when it comes to that. So as far as estrogen and cardiovascular risk, this is a very simplified diagram, but a lot of us understand that, again, age, #1 risk factor for cardiovascular disease. However, up until a certain point of age, men are at higher risk than women. Women are protected. And over time, we've noticed that it has to do with that drop in plasma estrogen during the time of menopause. This was the last time I checked. It was right before the meeting in Oxford. In June 11, 2024, I looked, and there were over 300,000 references in the literature about how estrogen is protective. It increases nitric oxide. It's so wonderful. And we agree. We did a couple of initial experiments where we cannulated vessels from healthy subjects. We did a dose response curve to 17 beta estradiol, and as you can see, it is a rather robust vasodilator. And that dilation is inhibited with both L-name and the nitric oxide scavenger, CPTIO. So we don't refute this. If you hang a healthy arteriole and you give it increasing doses of estrogen, you do generate nitric oxide production. So again, estrogen we know is typically associated with positive vascular effects and reduced cardiovascular risk. And as you can see here in the arterioles, we agree it's a nitric oxide stimulator. We got excited about estrogen a few years ago because it stimulates the formation of S1P. So there are these studies that came out recently showing that in the presence of estrogen, they saw increased activity of sphingosine kinase. And I kind of had a eureka moment. I thought, well, maybe this is part of the vascular protective effects of estrogen. Estrogen is activating this pathway. It's promoting formation of S1P. Like I said, S1P is an NO stimulator. It also amplifies pro-survival pathways in endothelial cells. And I thought, well, this is great, perfect timing. Because at this time, this is around 2018, the NHLBI came out and said, okay, everybody, we spent the last 50 years or so understanding how cardiovascular disease begins, the pathophysiology of it. We need to pivot a little bit and start understanding how can we make people more resilient to what causes disease. And I really like this concept. And I thought, okay, this is perfect. We could leverage this pathway, estrogen, S1P, again, try to boost up those protective pathways and see if we can make microvessels more resilient to stress. And so getting back to that high pressure stress that I talked about previously, we pre-treated arterioles with S1P, about 16 hours, just pre-treated them. And then the next day exposed them to that high pressure stress. And as you can see here, the open squares are the non-treated vessels. And as you can see, these are people who have at least 2 or more risk factors for CAD. So you stress them again, they lose the ability to dilate. But if you pre-treat them with S1P, you restore the ability to dilate to flow. So you're increasing resiliency of these vessels. So we really thought we were onto something here. So the second major hypothesis I want to talk about is that we thought estrogen amplifies the formation of S1P to boost those protective pathways within the microvasculature. So the first thing we did is to make sure, of course, that that was indeed the case, that in our system, estrogen was working through the sphingolipid pathway. So here again, we're doing that dose response curve to estrogen, but we're inhibiting neutrosphingomyelinase. The vessels don't dilate. We repeat this again. We go a little bit downstream. We give our small molecule inhibitor of SPK, of sphingosine kinase. They don't dilate. So again, the summary here is that yes, estrogen appears to be working through this pathway to dilate in response to estrogen and create S1P. So there are some trainees, I hope, in the room. This is the part I really want you to pay attention to. You know, when you're about to do a study like this, the first thing you do is you make sure that your treatment doesn't have just an overall general effect on your system, right? So the first thing we wanted to do was take arterioles, again, from healthy adults, and treat them chronically with estrogen 16 to 20 hours and make sure that they're still vasodilating to NO, right? Making sure nothing funny is going on. And I'm so glad we did that because that wasn't the case. And I kind of parsed out the data here based on age, but on the left, you're looking at arterioles from females under the age of 40. And as you can see, after we treated them with 17-beta-estradiol for 16 hours, they no longer use nitric oxide. They've now converted to hydrogen peroxide. The same goes true for arterioles collected from females over the age of 40. This is crude, but we were just trying to kind of figure out, pre versus post menopause, and we saw the same thing. But what's really interesting is there was a cohort of females we collected vessels from that after treatment with the estrogen, they just didn't dilate. And I will say that we always do these, we try to do these paired, and we knew that these arterioles were vasodilating to nitric oxide before estrogen treatment. So you have some that decided to convert to hydrogen peroxide, some that just don't dilate at all, signifying more damage. And then here, as you can see, the ends are a little high. It's because we didn't believe it at first. If we took the arterioles from males and treated them with the estrogen, again, they completely lose the ability to dilate. So the summary here is that, again, that chronic exposure actually might be promoting human microvascular dysfunction. In other words, when you're wrong, you're wrong. We were dead wrong. And this is tough. When you have a hypothesis, they tell you don't be married to it. I agree with that, but this was hard. And what do you do with data you can't really explain? You don't know what to do with? We shelved it, right? I put it on a shelf for a little while. Someone else came into the lab. I told them to do the experiment, not telling them what the former results were. They came back to me. I think they were scared to come and tell me the results and said, something's not wrong. Something's wrong. This isn't right. And I said, well, what do you mean? Well, it's causing dysfunction. Okay. Well, then I knew something was happening. It's okay. It's, it's the universe trying to tell you that we don't have the full story. And that's all right. So we went ahead and published this in 2023 as a rapid report for AJP Heart. I was a little nervous, to be honest, about submitting this data. And on Saturday, it'll be winning an award for the most cited and downloaded rapid report in 2024. So when something like that happens, what's neat about our laboratory is we are able to translate our studies from the bench to whole humans. And so we started a clinical study to try to understand what is the effect of chronic estrogen on human in vivo microvascular function. And the study looks a little bit like this. So we started out with the males because we saw the most dysfunction in those vessels from males. And so we recruited individuals assigned male at birth, ages 18 to 60, no risk factors for CAD. So as you can imagine, most of them were on the younger side. And they were either estrogen naive or taking continuous estrogen daily for at least a year. We then bring them into our translational research unit for about 4 hours. We take a plasma estrogen blood draw, and then we do a couple different techniques. We use incident dark field microscopy. I know it's not perfect. We have to go into the mouth, and we just want to look at microvascular density. We want to make sure that if there's a change in function in the periphery, that maybe it's not due to rarefaction or something like that. We then utilized laser Doppler fluorometry with microdialysis. You basically insert mini catheters into the arm, and you can infuse acetylcholine as well as other vasoactive drugs, and look at red cell flux as an indirect measure of microvascular function, but it is currently the gold standard. And then at the end, we do a survey using the NIH toolbox, looking at mental health and substance abuse, because that can happen in this population. So these are very, very preliminary results. And unfortunately, this study has now been put on hold. But those individuals assigned male at birth, when we infuse 1 millimeter of acetylcholine, as you can see, those on the estrogen, you see a reduction in the skin vascular conductance or red blood cell velocity. We see the same thing at 10 millimolars, a higher dose of acetylcholine. And then here we're just looking at plasma estrogen. It's a little variable. It's very preliminary. It's only an N of 3. But as you can see, depending on how you take your estrogen, some of them take injections, some of them take it orally. You can really have varying amounts of estrogen. And then here we're just showing the data a little differently, looking at plasma estrogen to dilation, and those three with the higher amounts of plasma estrogen have a lower response to acetylcholine. So yes, in vivo microvascular function, we'll say might be impaired in individuals who are male taking supplemental estrogen. So as far as getting back to that microvascular density question, again, this is the cytocam that looks at microvascular density. And just to be thorough here, we look at 2 markers, perfused vessel density and microvascular flow index, which is really just kind of the quality of the flow. And as you can see, both of them appear to be similar. So the differences we're seeing in function, again, it's hard because it's the mouth. It doesn't look like it's due to rarefaction or a decrease in microvascular density. So the next question we asked is getting back to that ceramide question, since we were wrong, since it causes dysfunction, and we know that it stimulates the neutral sphingomyelinase pathway, does the chronic estrogen result in ceramide accumulation? And so for this experiment, we went back to a cell culture model and just used UVEX because we can use sex-specific cells here. And so we treated these cells for 48 hours with 17 beta estradiol. We then used mass spectrometry to look at those results. And what I did is I summarized it here based on total ceramide, even though, of course, we've looked at every single isotype. But in summary, these are the cells from females. And as you can see, we use 2 different doses of estrogen, 1 nanomolar, which is actually the peak natural concentration you would see in the plasma in someone not on estrogen, and 100 nanomolars of estrogen, which, yes, you could argue is kind of high. But all those 300,000 references I looked at, most of them used 100 nanomolars or higher to show that it was vascular protective. We then compared to the males, and what you can see here is males have a much more robust response to creating ceramides in response to estrogen. I just want to point out, obviously, the y-axis there. So the 1 nanomolar and 100 nanomolar dose, you see this significant increase in ceramides. And so yes, ceramide accumulation in endothelial cells is occurring in response to chronic estrogen, and that response in males is more robust. Taking it one step further and looking at more sex-specific differences, we also took the sex-specific UVEX and, of course, looked at hydrogen peroxide production. And so here we're looking at the formation of hydrogen peroxide in response to the 100 nanomolar dose. And then if we inhibit the pathway, the neutral sphingomyelinase pathway, you can see that we bring it down. Those are the results in females. And then what's interesting is if you look at males, yes, it's the same trend. Hydrogen peroxide production goes up. It's inhibited by the GW compound. But again, if you look at the y-axis, women actually, at least the cells from women, are generating more hydrogen peroxide. So compared to males, it looks as if females generate more hydrogen peroxide in response to estrogen, which is suppressed when you block neutral sphingomyelinase. And we did the same thing functionally too. So this is just me wrapping it up here, showing that in the arterioles from females, again, if you were to inhibit neutral sphingomyelinase now, so here we wanted to use estrogen to stimulate this pathway to make vessels healthier and more resistant. Now we find ourselves inhibiting this pathway to protect them from chronic estrogen. And we can actually or start to restore. It's not significant yet, but we can start to see that it's moving back towards NO production. And in the arterioles for males, again, they get treated with estrogen, they can't dilate. If you inhibit the ceramide production, you're actually able to restore dilation. So to summarize here, I hate it when I'm wrong, but here we had to inhibit neutral sphingomyelinase to prevent, again, that damage due to estrogen. And then finally, I thought this was interesting. This is something that Gopika did before she left the lab. She wanted to know if the estrogen signaling, which again, I showed you acutely, we can produce nitric oxide acutely in these vessels, but she wanted to know that, okay, what happens after these vessels are treated chronically with the estrogen? And I'm so glad she did that. Because here again, we can see in a control vessel, they dilate nicely to estrogen. But then what's interesting is after they've been exposed to that estrogen, as you can see, they're significantly inhibited from estrogen. And what's interesting is, in this case, if you block the sphingomyelinase pathway, you can't restore it. So there's something else going on there, but basically telling us that if you're on it chronically, you may not have the same beneficial effects. So you might be just as confused as I have been when it comes to this project. After all, we have, again, so much data showing that estrogen is protective, and it's not that it's wrong. And it's not just menopause either, right? Anything that causes premature ovarian failure or a loss of plasma estrogen, we see this increase in cardiovascular disease risk. But again, it's not the whole story. And we now know, big studies have come out in the last year or two showing that women who are on oral contraceptives for years and years and years are at higher risk now for developing cardiovascular disease. So we have a lot to learn here. And I guess my summary to this is similar to the ceramide story. Estrogen likely has a hormetic effect on human microvascular function. And maybe that's no surprise, right? Because that's how a lot of things work in biology. So how do we explain this? Again, as a cardiac anesthesiologist, these are monitors that I look at a lot. And I can't help but to think everything in physiology has a rhythm to it, right? Our heart rate, our blood pressure, pulmonary artery pressure, CVP, everything has a rhythm to it. Our sleep patterns, circadian rhythms. And the same holds true for sex hormones, right? I got to be honest, as a woman, I don't really want my hormones to fluctuate. It doesn't make you feel good, but that's the natural rhythm of it. And there might be something with the natural fluctuation of estrogen that's causing the protection, that's causing it to be nitric oxide stimulating, whereas the chronic non-cycling, whether it's low and continuous or high and continuous, might be leading to those controversial effects in cardiovascular disease. So again, this is something we're working on right now. We're developing a system to look at fluctuating concentrations of estrogen, and we'll get to the bottom of that. So to summarize this last part, acute estrogen-induced nitric oxide signaling, yes, it does look like the sphingomyelinase ceramide pathway is involved there. Chronic exposure to estrogen looks like it's promoting microvascular endothelial dysfunction ex vivo and possibly in vivo. We're going to try to finish those studies. And inhibiting ceramide formation prevents estrogen-induced human microvascular dysfunction, something we thought we wouldn't have to do. And I know what you're thinking. What is she ever going to get back to the resiliency question? Can we leverage the ceramide S1P pathway to increase resiliency to stress? And the answer is yes. We're working on a couple of different pathways right now, but I believe my time is up, and I think I'm going to stop there. So I just want to give some quick acknowledgements. You're only as good as the people around you, and these are the people in my lab. I just want to say thank you to Henry and Brian. Henry is my lab supervisor. Brian is a research associate. These two keep things going when I'm here, when I'm in the hospital working. They're great with the trainees. Again, I want to point out Gopika Senthu Kumar. She's sitting next to me here. She was the one who generated, I would say, probably the majority of the data in this presentation. She has now gone on to finish medical school, and it took two of her to replace her. So now I have Rachel and Rashi. These are two graduate students who are just getting started. And Rachel will be giving a presentation on tomorrow at APS. I want to thank the vascular biology group at the Medical College of Wisconsin. I still can't seem to take his name down, right? Because we're all descendants, all of us listed here have trained with David Gutterman. But this is a wonderful group of people to work with. We share equipment, ideas, we support each other during tough times. I'm really lucky to be a part of this group. I want to thank my Department of Anesthesiology and my chair, Cindy Lean. After all, she's the one that protects my time. We're in a national shortage right now of anesthesiologists, but she's managed to protect me and allow me to do this important work. I want to thank the Cardiovascular Center, that's now led by Mike Woodlansky, and they house my lab, our funding sources, and of course, all the hospitals that give us the tissue to do this translational work. So with that, I just want to say thank you again for having me here. And I'm happy to take any questions.
Thank you, Dr. Fried, for this wonderful and very insightful presentation. So now I would like to open the floor for questions from the audience. So please feel free to raise your hand or submit your questions through the chat.
Thank you for that beautiful presentation. I was just curious if you've looked at any role of peroxisome, since estrogen stimulates peroxisome proliferation, and obviously the main source of catalase, but also a lot of lipid metabolism. So I was wondering if that could have a role in regulating dilation of the microvasculature.
Interesting idea. The answer is no. We haven't looked at peroxisomes, but you just gave me a great idea. I mean, right now, I think this is still kind of the early stages for us in trying to figure out, again, what's causing this dysfunction. But I think that's a great idea. Thank you.
Thank you.
Thank you for a nice talk. I was just wondering, like in the pulmonary circulation, SP1 is detrimental. It causes vascular remodeling as well as it decreases endothelial dependent relaxation of pulmonary circulation. So do you have an idea what are the different mechanisms? I mean, of course, pulmonary and systemic is not the same, but do you know what the differences for pathology is?
Well, that's just it. You just said the magic word, pulmonary, right? I mean, the pulmonary and systemic circulations are just so different. I'm not surprised. And I have seen that, you know, the S1P is more detrimental in the pulmonary vasculature. I don't know. But the thing is, it's also the ratio sometimes. So I like to tell people comparing S1P to ceramide is very similar probably to LDL and HDL. To a certain point, it's a ratio. But then it doesn't matter, you know, what your ratio is for HDL and LDL. At a certain point, you get too much cholesterol, it's going to cause damage. And the same thing is happening, we see with the sphingolipids. So in heart failure, we see a high amount of S1P and ceramide in the plasma. So as far as what's happening in the pulmonary circulation, I don't know, because I don't know the level of S1P that you're talking about, and I don't know the level to ceramide. But again, you said pulmonary, so things are usually quite the opposite there. It's a good thought.
I was curious, in the specimens that came from the patient.
Yeah.
Was there any notable change in myogenicity?
I don't know. I think what's hard is we get very limited information from these patients sometimes. Again, if it comes through the true I call it the true discard way, you'll get, you know, age, again, sex, BMI, maybe some major comorbidities for us to determine if it's healthy. A lot of times we have to run control experiments on these vessels just to see, are they truly healthy or not? But that's rather limited. So no, we don't quite get that sort of detailed information. Yeah. The established transmural pressure. Well, now we're going way back. So the pressure inside the vessel is 60 millimeters of mercury. That's the ideal for the human. Yeah, for the human microvessels, it's 60.
Ceramide still in women's cosmetics.
Yeah, you know, if I had $1 for every time somebody asked me that question, those are the same ceramides. And David, if you're listening, if David Gutterman is listening, he always challenged me and said, you know, they came out with all these creams, now with ceramides. And he said, you know what you need to do? We need to find a medical student to do a study where someone's putting those creams on and to see if it causes microvascular dysfunction. But I get that question a lot.
Yes, thank you very much for this wonderful talk. I stay here because my question is not really my question. I just talked to Gabe. And
oh, dear.
Gabe called me to ask the question that where are the prostaglandins?
Where are the what?
The prostaglandins. Where are the
Prostaglandins.
prostaglandins
Oh, I
in
know.
this whole
That's just it.
system?
Trust me, they're there. They're there.
Do
Because
they have
you
any
know,
function in this flow-dependent dilation or with the ceramide?
yeah, they're there. I mean, in fact, if I won't go back to it, but if you looked at a lot of those flow curves, there usually is residual dilation left, right? And you know,
Did you
Gutterman,
use indomethacin to
sure,
see?
we could use indomethacin if we want. But I think when you see that drastic, significant reduction, again, we know the primary mediator is what's responsible there. But there's always residual dilation. I shouldn't say always, there's usually residual dilation. And if we add indomethacin, then I guarantee you it would probably take it all the way to zero. So they are playing a role, just not a primary role. Now we know that in children, in the human microvessels from kids, they primarily rely on prostaglandins. But as we age, then we go to nitric oxide, and the disease, we get pushed to hydrogen peroxide. So they're there. Tell them, and ask them if I got into the inner
Okay, I
circle.
will talk to you. Yes, thank you.
Yeah.
Julie, thanks so much for that talk. Gabe also told me that I should ask you a question.
Okay.
No, I'm curious, and maybe you mentioned it and I missed it because I'm quite ignorant of this biochemistry, but what is the mechanism by which ceramide actually enhances NO signaling? Is that clear? I mean, you took it to the first enzyme.
And that's just it. I focus on these vessels so much. I should have broken down that pathway a little bit more. But again, little small bouts of ceramide will get hydrolyzed quickly to sphingosine and then rapidly converted to S1P. S1P, I didn't show it in this talk. S1P participates in inside-out signaling. It actually gets it gets extruded outside the endothelial cell, and then in an autocrine manner acts on its own receptors to activate endothelial nitric oxide synthase and generate NO. So small amounts of ceramide, right? You're stimulating the pathway to form S1P and activate eNOS. Now you cause accumulation, or you plug up the system and ceramide starts accumulating. That's no longer the case.
So S1P has a receptor. It's
there's
like
actually
a GQ
5.
coupled receptor or something.
Yes, there are 5.
Five.
Yes, in the endothelial cell, 1 and 3 are the major players. But even the smooth muscle has S1P receptor 2. I want to say 3, 4, and 5, but there are 5 receptors. Yeah.
Right. So it's a paracrine or autocrine almost.
Autocrine.
Yeah,
That's
I
right.
see. Great.
Yep.
Thank you very much. I didn't know.
Sure. Yeah.
Hi, thank you so much for that amazing talk. I have a really, I guess, naive question. Would you expect, depending on where the samples came from, would you expect all microvasculature in the body, for example, in the brain, to have the same behavior and the same trends in terms of the switch between nitric oxide and hydrogen peroxide?
Ooh, it's a tough question because I don't study the cerebral vasculature. I don't know.
I only study that.
Are you a brain?
In
Are you a-
neuroscience, yeah,
okay,
yeah.
Okay, well, I will tell you this then to appease you. A lot of the ceramides we get come from the brain. The brain is a huge sink for ceramide. And a question I've always thought of is when we think of mental stress on the brain, right? Anxiety, depression, things like that. Is it causing a release of ceramide into the systemic circulation? Is that what's also triggering cardiovascular disease, right? Because we know mental health also is a risk factor. Yeah.
Thank you.
Have you had a chance to look at antioxidant enzyme expression in acute estrogen treatment versus long-term chronic? And could that explain some of the differences in the vasculature?
Yeah, well, I'll tell you something really exciting that we're doing for the first time ever. We are doing RNA-seq, and we are actually now doing spatial transcriptomics on these vessels. And we're waiting any day now for those results. And so that is going to be interesting, is to take an unbiased approach and look at and see what is going up, what's going down. And so we kind of, we put our chips out on the table a couple different ways. We're doing the bulk smart-seq, but those are whole vessels. So now it's like, well, you don't know whether it's coming from the endothelium or the smooth muscle, but then hopefully with the spatial transcriptomics approach, we'll be able to see what's happening specifically in the endothelium, what's coming up and what's going down. Yeah.
Thank you, Dr. Fried.
Great.
Thank you all. So if there's no more question, I would like to invite Dr. Wallin for the ceremony award.
I'd like to very much thank you, Dr. Fried, for giving the 11th annual Drs. Gabor and Harriette Kaley lecture today. Your lecture clearly had many new concepts and how the microcirculation is very, very important. And the title of your talk, Translational Tales of Human Microvascular Endothelial Function, really matched the lecture you gave, and it is just loaded with good translational concepts that may turn out to be very, very important as we watch the future of this field evolve. So I have the honor of giving you this plaque, but thank you ever so much for coming.
So I got the task to close this session. Please stay with me for 2 more minutes. First of all, I would like to emphasize that, this Kaley Award, the Harriette and Gabe Kaley Award level is really greatly elevated by our awardee. And also I would like to mention that on the Zoom, previous awardees are there, Kim Dora, Fabio Recchia, and Mirai Cipolla. So we say them hi. And also there is 38 people on the Zoom. So it's really a great thing that so many people are interested in this award. And I would like to thank you again for coming. And also I'm very happy that Harriette Kaley is here and hope she will come for the next 11 award meeting as well. With that, I will close the session. Thank you.